as we say in Trinidad. But where's Dr. Rondu? What happened to Chait? So we envisioned a coding challenge this time. It was to spend 10 days intensely coding some problem. Hurricane Milton made sure that did not happen. It turned into 2 months, and I subsumed these guys into my lab. So we didn't actually have a coding challenge. We had a mentored challenge, so to speak. So I'm going to let them tell us what they did. So,
Well, thank you, Dr. Hadley. My name is Rishi Nair, and that's Nicholas Mystery. We're both undergraduate students at the University of Central Florida, and we're also both interns at a startup cancer diagnostics company called Protean Biodiagnostics. If you're familiar with Dr. Anthony Malioco, he is our PI. So we initially submitted a poster with Dr. Malioco as our PI, and apart from that, we found out about the coding challenge. So Nick and I sort of took it upon ourselves to also do an AI training model for DNA methylation, specifically in lung cancer, which is a little relevant to what else we submitted with our poster, but we're excited to present sort of a pseudocode and the framework of our project to everyone here. We have no disclosures. Okay, so our mission statement between the two of us, which is very aligned with where we intern, is to find and refine effective non-invasive methodologies using AI to both help doctors save time and help improve patient care. So first, let's get into what DNA methylation is. DNA methylation is a type of epigenetic modification, which basically means modifications to the genome that occur outside the genome itself. Usually, epigenetic modifications take place either after transcription or after translation. Methylation and its sister, acetylation, occur after transcription. DNA methylation results in long-lasting changes to the genome, which is unlike histone methylation, which is reversible. And DNA methylation specifically occurs at locations of sequential cysteines, cytosines, and guanines, so C's and G's on the genome. That's where the DNA is methylated. And it also has the potential to be a novel method of cancer detection. Specifically in patients with lung cancer, it has been hypothesized that if a patient coughs up mucus or sputum, that can be analyzed for DNA methylation through other forms of liquid biopsy as opposed to an invasive procedure. And it's also worth mentioning that the word methylation, as most of you might know, is just the addition of a methyl group, a CH3, to that location on the DNA. Okay, so we have a 4-step process for this project. First, we had to download and process the data from cBioportal. If you don't know what cBioportal is, it is essentially a repository that contains probably hundreds of clinical trials and cancer-related patient data that can be used from both a clinical and genomic perspective. And then after downloading the data, we had to compare it with the given survival statistics on cBioportal. So we're going to show this a little bit in depth later, but furthermore, our main point was to generate a survival score between the methylation data that's on cBioportal as well as the survival statistics, which are also on cBioportal. The issue is those two things aren't linked together. So you can see methylation data purely from the genomic perspective, and you can also see whether or not the patient is alive or dead after a certain point in time. But there's no way to bridge that gap, and that's what our aim is to complete. Yeah. Next slide. Okay, so the study that we used on cBioportal contained roughly 590 patients, and of those 590, 460 of them had methylation data from a proprietary chip called HM450, which analyzes almost 500,000 sequential sites of cytosines and guanines on the DNA. We excluded data from a prior version called HM27, which, as you can see, has less cytosine and guanine sites compared to the former. In this data, we can obtain something called the methylation beta value, which determines how methylated a specific site is compared to the rest of the patient's genome. So this is an example of the data that you can get from cBioportal. This is a log-log plot, and in this specific one, we determined, so A and B represent whether a patient is older than or younger than 60 years. And this determines the methylation for all the genes simply based on cutoff of 60 years. As you can see, this is not very useful from a computer science perspective or a patient perspective, because you don't really know what this is telling you. The only thing we can figure out is that each dot represents a gene, and the ones in blue represent genes that are significant in terms of both their p-value and their q-value. Furthermore, this is an example of a survival curve that Kaplan-Meier, most of you guys might have seen this. Same thing, you can set a cutoff of 60 months, and you can determine the p-value in terms of whether or not the sample is alive or dead at that point in time. And if you were wondering for the plot, the scatter plot, the volcano plot, 2 slides ago, these were the 7 genes in blue that were significantly altered in terms of their methylation status between patients younger and greater than 60 years of age. But again, this doesn't really allow you to predict whether a specific methylation pattern is correlated with worse or better survival. So again, that's what we wanted to figure out. Okay, so like I said, each patient has a methylation beta value for each gene. So if we know that there are about 20,000 genes in the human body, that's a lot of beta values that you can run for all 500 to 600 patients in any given study. And the good thing about a beta value is that you can compare a patient's methylation status for one gene to other genes of that patient itself. So you're not going to confound the data with other patients who might have had different life experiences or eating or drinking habits that might impact their methylation value. We then need to train our data with an AI model to minimize the loss between the prediction of survival and their actual survival outcome at 60 months. And then we plan on using around 20 to 25% of the data to do the training and feed the remaining data for testing. Afterwards, our goal is to generate 2 types of predictions based on this model. One is P sub D, which would be the probability of the probability that a patient dies before 60 months, as well as their expected overall survival in months, irrespective of whether or not they are alive or dead at 60. So I'm going to turn it over to Nick to go in depth as to what we did in terms of AI.
Yes. Hello? Okay. So we're looking at, we're taking our data, which is we get from C Bioportal, and then we're using it into a denoising model, which is similar to a principal component analysis, or to put it simply, we're just trying to pick the best data from the sample. So if we get like a huge patient, there's around like 16,000 genes we can look at. So we're just trying to filter it out and try to look for the most significant ones. But that also enables us to use clustering, which I will explain later. So we take that and we make 2 different models called expected survival months and expected survival, which the months will give us like a number ranging from 0 to 60. Expected survival will be 0 to 1. And then the decision step is where we be like, okay, so we have this methylation pattern. Can we determine if this methylation pattern can lead to worse overall survival or greater overall survival? And then we can put that as output. So the clustering, so if you look at the denoising model, the way I can explain this, so let me go to this slide. So we can split the clustering model into 2 steps. The first model will determine a signature, and the second model will try to reconstruct the data using the signature. But with that thing, so we have a denoise output, but we also have a signature that we can also compare all the patients to, so that when we're looking at analysis or like experiment or a design of experiment, we can look at, so this is the patients that we have. Patients with this methylation signature have a worse overall survival compared to another group, which is very useful, especially for doctors when they have to look at drug resistance or trying to classify the patient they have right now. So then the decision step is where you take all this data now you have, and then you can be like, okay, so this group has a worse overall survival, and then this group, and then we can use that with treatment data to make a more usable output. So the pseudocode, so for each patient, we run the denoising autoencoder to obtain the code or the signature, and we have the denoise data, and then we train with expected survival in months, and we train expected survival which is the probability. And then for each cluster, we compute the P and E, and we run the thresholding, the comparison between that and everybody else in the cluster, or all the clusters, and then we can use that to make an educated guess about the signature and its expected survival. And then for validation, we can use Cox regression to determine the amount of statistically explained values. But like obviously, the problem with this is that it can be inaccurate, or it can have false positives, false negatives. So then we also have to use this with experimentally verified methylation patterns. But the Cox regression also allows us to look at confounding variables and potentially account for synergistic genetic alterations. So our first step when we're trying to do this investigation, especially in the future, is that we have to look at all the models that are currently available on the market or in the research papers, such as autoencode for denoising, generative adversarial networks for expected survival, and transformers for expected survival months.
Okay, thank you, Nick. So in terms of the future directions for our project, the first thing that we need to do, like he said, is to compare the scores that our AI model generates with experimentally verified methylation sites in order to determine methylation hotspots that in the future can be used to predict cancer survival simply based on whether or not a patient's genes are epigenetically modified in a different manner compared to non-cancer patients. Additionally, we would need to correlate this data with chromosomal locations because apart from the linear sequence of DNA, the specific location on the chromosome might also play an impact on whether or not a patient has cancer. DNA methylation specifically reduces the expression of genes. So it would be oncogenic if it reduces the expression of a tumor suppressor gene. But to the contrary, histone acetylation is an example of an epigenetic modification that increases the expression of genes. So not only can methylation be used as an epigenetic marker, but acetylation can as well. Third, we have to correlate our values with the function of the genes in a downstream model. So even if one gene is expressed more or less in cancer patients compared to non-cancer patients, what is the impact, right? If it's just in the middle of a signaling pathway in the cell, and that signaling pathway is regulated by other mechanisms, maybe it can be counteracted by a drug or a natural mechanism that we might not know of already. And finally, the potential utility of our project, apart from the downstream effect, is to determine whether or not those loci in cancer patients differ not only within the patient in terms of different tissue sites, but also between patients within the same organ. So yeah, that's all we have. Thank you very much. Any questions?
I have so many questions. Firstly, what is the balance of the categories in your data? Like, how many have developed the disease and those who don't? Like, how balanced is the data set?
Okay, so if I recall properly, so about only 70 to 72% of patients even had their methylation data accounted for. And in terms of the overall survival, can you go back to the Kaplan-Meier? Okay, so as you can see, I'd say 30% of patients survived at the end of the entire study. So this is only based on age. You can set any groups that you want, but if you look at the very end of it, I estimate probably 20 to 30% had overall survival at the very end.
Okay, so that's the survival data. So you're doing two different types of modeling. You realize that, right? You're doing a classification, and then you're doing a kind of a time series analysis.
Yes.
So for both, there are two different modeling sets. And one, if there's imbalance, there's going to have completely different effect on the algorithm. You have to choose different algorithms. And I'm not sure why you're using Cox. I guess for survival, yes. But you're doing AI. There's so many other algorithms, naive Bayes and support vector mechanisms, all of these that you need to look into.
Hello? Okay, so we're just trying to work with the data that we have, which is from See Portal. And so that gives us patients that have cancer, right?
Right.
And so assuming that they all have cancer, and so we're just trying to correlate that to methylation patterns because they're all very distinct. Like if you look at the clustering, you might see different types of clusters based on different methylation signatures and or mutations that they have. So we're trying to use that, leverage that information to correlate to survival.
Yeah.
And the pre-existing thing that people like statisticians have done in the past is use Cox regression. So we wanted to prove that if we can make an AI that's better than like the pre-existing tradition of using Cox regression, then we can use then this will be a very viable option.
But I'm lost because you want to prove that the AI is better than Cox, right?
Yeah.
But what AI do you use? Or
Sorry.
did you use? Or
No.
So what model did you use? What AI algorithm?
So okay, so when you like in literature, there's a bunch of like pre-existing like there's a lot of AI models out there.
Right.
The problem that they have is the amount of false positives. So the way to counteract that is to see how much of those output like these values that we get, how much can they explain to statistically,
Yeah.
and that can also give us like a gauge of accuracy.
Right.
But also knowing that statistics has its own limitations, so we have to look at experimentally verified. So then it's just a way to try to gauge how accurate is our model compared to other techniques and try so we can choose the best one.
But it's still the Cox model.
Sorry?
Okay. Yeah. So choice of model and separating out the two types of algorithms. I don't know why you guys are combining the classification with the survival because they're two different tests. But the way you would, how you're processing the data would be different. Interpreting the data. What kind of metrics are you guys using for the classification? Those are some of the issues.
Yeah, I understand. So basically, what you're saying is that the methylation data, the log plots only tell you how methylated a specific CPG site is for one patient, but the survival analysis is totally different.
Yeah.
And your question is how can we like are you asking how or why can we?
Why?
Because we think it's important because just because a patient has a genetic alteration, it doesn't necessarily mean that they're going to develop cancer. And likewise, even though a patient has cancer, their genomic sequence might not be altered compared to the rest of the population. Specifically for lung cancer, as you know, many people smoke, they vape, they do a lot of different things that might change the expression of certain genes in their lung tissue compared to non-smokers and non-vapors. Our model is an attempt. We still need to test half of it. We're still presenting pseudocode, but our model is an attempt to see if we can accurately predict survival data simply based on methylation status, and if so, what methylation sites in the genome have that, what methylation sites in the genome can be classified as hotspots for that data to be considered accurate. It may work, it might not work. We know that the data can be downloaded, it can be analyzed, and it can be trained. Next, what we have to do is actually plug it into the other studies on See Portal for lung adenocarcinoma, and then figure out if the data is accurate. If it's accurate, what Nick said is right. If it's inaccurate, then we'll concede to you. But one other thing that we mentioned at the end is the possibility of drug resistance as a confounding variable. That's something that we're trying to account for not only in this study, but the other one that we also submitted for the poster competition, which separate to this was based on breast cancer. In order to account for drug resistance, we took a different approach, but for this as well, by looking at synergistic genetic alterations. For example, if a patient has alterations to both HER2 and cyclin D1, what drugs work better or worse for those patients compared to those who only have one of those alterations. That might also confound the data that we're analyzing for methylation. So, like you said, it's very complex, but we feel that it's necessary to at least test it because environmental factors, especially in lung cancer, do play a role in whether or not the patient survives and how far the disease progresses.
Yeah. And that's the case with a lot of medical prediction, right? Because that's what I did my PhD on, disease prediction. So when it comes to these kind of things, you have to think in terms of the probability of whether you have the methylation or not is one thing, and then the probability of once you have that, then you may develop the disease. Then there are other factors, and so that's where the idea of a dependencies-based theorem and those kinds of things are important, right? Because you don't want to confound the classification of whether or not they have with the like the survival time. So the thing is, you have to. I understand why you want to. Yes, if you do have the gene, then you want to know how long. But those are kind
So you're basically saying that the external validity might be compromised if we don't know the probability that the methylation occurs in the first place.
right.
Okay.
And so the probability that you may report may not be accurate. So that's something to think about.
There's a lot to think about. All right, we have one more student. Thank our lovely students. Good job. Ashley. We have two more students. Ashley, and then we're going to play a video, and then I'll send everybody home.
Appreciate it. Hello. My name is Ashley, and I'm just going to talk to you guys just a little bit about the project that I mentioned a little bit earlier called Allay AI. And basically, our mission and our goal here is to give doctors the opportunity to spend more time with their patients and essentially take away the extra time that they're spending on administrative tasks, on documentation, and things like that so that we can alleviate burnout to some extent. So, just as I said before, some of the main reasons that we've talked to physicians about why they're burning out is because of too much paperwork and spending too much time in the office doing this paperwork, essentially. And, a lot of us, like as a first-year medical student, I want to go into medicine because I want to talk to patients. I want to see what's going on with them. I want to develop relationships with my patients. But I'm finding, doing clinical skills with these patients, I get, less than 20 minutes to talk to this patient. I don't even have time to ask them half the things that I want to ask them, and the rest of the time is going to be spent writing this note for the patient. So our goal here, and some other things that physicians have to do are to essentially, they'll consult with the patient, then they'll come to some kind of diagnosis during that meeting with them. Then they're going to manage some sort of plan with them, document the whole thing in a SOAP note. They're going to summarize that, submit that, make sure that they have all of the medications and everything that they want to do. Then they're going to track it, and finally, at the end of all of that, they're going to end up having to work with insurance companies and everything to make everything work. So obviously, that's a lot more than just that nice patient-physician consultation that they are more interested in doing. So, in addition to that, there's a lot of cost in terms of actual revenue as well as with your patients. So because of all of these things that they have to do, they're spending a lot of money and time on operations. So for example, let's say they don't want to do the documentation, they're going to hire a scribe to go ahead and write all that information down for them. Or they're going to hire someone to be the middleman with insurance companies and check their notes, make sure that the insurance companies think that's sufficient, and then they'll go back and forth multiple times to make sure that that is correct. All of that is a loss in the revenue by about 30 to 40%. In addition to that, there's lower patient satisfaction because they're spending a lot of their time and mental energy on all of these other tasks that need to be done, as opposed to just talking to the patient, figuring out what's going on with them. And the last thing, again, as I was mentioning, was the physician burnout, which can lead to errors and other things that also lead to costs, which can be up to $4.6 billion annually. So, in comes LAI. Our goal is to simplify that data management, reducing the administration tasks and enabling better communication between physicians and their patients. So the way that we're doing that is with a few features. So the first one is an automated scribe and summarization feature. All of this will be demoed at the end, but essentially the first thing is basically it'll sit there with the patient, you'll play it, and it'll listen to the conversation between the doctor and the patient and create a nice summarized note for the doctor that's already like it goes with what the insurance companies want in terms of billing, so that way they can remove that in between writing the note and sending it to the insurance companies. The next thing is a real-time translation feature, which essentially will work in the same way as a scribe. However, let's say you have a patient who speaks Spanish, who speaks Vietnamese, anything basically that's not English, and you don't want to hire a bunch of translators for this purpose. In this way, we have an AI where it listens to the conversation and can translate it in real time for the doctor and the patient as well. And by the end of it, it still creates a nice SOAP note in English for the doctor to listen to. And then the last thing, like I was mentioning a little bit earlier, is the integrated medical billing side, where basically to take the note and make sure that it's what the insurance companies want, in a sense where they don't have to go so much back and forth to make sure that the insurance companies are able to pay them, essentially. Oh, and one more feature that we're still in the works of is the asynchronous communication feature. Some of our doctors have mentioned that talking to the patient afterwards can sometimes be very time consuming, going back and forth over text messages, or just being in contact with a patient. It may be difficult to call them and then, leave a message, and then they call back and leave a message, and it's just hard to communicate with patients outside of the office. And so this is a messaging feature that we're using to kind of integrate with the notes that they would have taken during the consultation with the patient, and it'll remember that information in this note when talking to the doctor, so that, like, let's say they're like, oh, I want to take ibuprofen for my fever, can I do that? It'll take a look at their notes, see what medications they're taking, make sure there's no contraindications or anything like that, and kind of write up a sample response before the doctor can go ahead and read it and send it to the patient. So that cuts out a lot of time on the doctor's end, as well as make sure that they don't miss something that maybe could be a problem. And just to make this even easier, we're trying to integrate with the EHR systems so that everything is in one place. They don't have to use a bunch of separate apps for everything. All right. So the goal is to then save doctors time, ideally 3 to 4 hours per day that they would be spending on all of this documentation and administration tasks, giving them the ability to talk to their patients for more time and give them more attention that they want to do, and also reduces their burnout overall so that they make less errors. All right, so the much awaited demo. Let me see if it'll actually play the sound.
Good morning,
Oh,
Miss
yes.
Goyle. How are you feeling today?
सुश्री गोयल आज आप कैसा महसूस कर रही हैं?
मैं बिल्कुल ठीक नहीं हूँ। कुछ दिनों से काफी तेज बुखार आ रहा है।
I am not feeling well at all. I have been having a high fever for a few days.
So I'm not sure if you guys can see this, but this is the organized note that would come after the conversation. The doctor is able to review it and edit anything that they would like. They can also go review it later, and this is an example of the messaging where it creates a message for the doctor based upon the question that the patient asks, and they can just review it. They can edit anything they would like, and then they can send it. And that is able to save them a lot of time in the long run. Yeah.
For my tree
Thank you.
brethren here, we're going to have to keep it moving to get people going. So we'll hold questions till after. My friends, you want to show my one more video? Okay. Thank you, Ashley. That was awesome. All right, we have. Is this the final video? Does anybody else want to present anything? You? After? Okay, we have 2 short videos. This one is going to be a high school competition. This kid is in high school. He's going to win the high school prize because nobody else entered. But let's see what he had to show.
Hi everyone, I'm Pratik. I'm fortunate enough to be working with HSI Labs in Anurag as well as Deepa and Dr. Hadley from UCF. And today I'm presenting our project on an experimental design for AI versus a physician-written SOAP note. And so let's get into it. So a SOAP note is a note that physicians use after a meeting with patients that have generally 4 parts: subjective, an objective, a assessment, and also a plan. And typically they're written by the physicians or physically scribed, which results in a lot of costs. And we'll get into exactly how our research can be used to demonstrate how we can reduce long-term costs in clinical settings using AI-based notes. So the biggest question is why? Why should we care about AI's notes compared to human notes when it's seemingly costless? We can just write down the notes as soon as our patient meetings are over, and they shouldn't be too harmful. The issue is that there's a lot of challenges in the traditional human-based SOAP note documentation. Two of the biggest ones would be the time it takes. While one note might not take too long, over the course of a whole day or the whole week, lots of time may be used using manual data entry. The second biggest issue is that research has demonstrated that in the long term, there's a high risk of physician burnout. The amount of documentation contributes to fatigue in the long term, which also results in less quality care and reduces overall benefits of healthcare. And so that is a big cost that research has identified in the long term, which is really valuable to solve. And so the other issues as well is that AI can be more standardized, so we can resolve inefficiencies. AI can also be more accurate than humans can be on average. And also, it ensures that notes meet some legal and some insurance standards, which AI, again, is another form in which you can directly standardize the format of note-taking. So what would AI's impact be on general patient care? Well, again, like I previously mentioned, the biggest areas would be better documentation is better care. When physicians are able to make more accurate notes, the clinicians and the physicians are also able to provide more reliable data and can use that data to guide treatment decisions for the patients and optimize their results. We can also allow faster decision-making to be made. When AI can immediately produce a note as soon as a conversation is over with the patient, the physician and the clinician can look at the note promptly and be able to make the best decision. And again, also is just from the consumer side or the patient side, patients are able to have higher satisfaction with their clinical setting because they are able to be provided the most amount of care in the most optimal time, and we can just optimize the workflow in essence. And again, like I previously mentioned, the AI scribe will not just benefit patient outcomes, but it will also just benefit the whole healthcare provider and the whole clinical setting by improving time, reducing burnout, improving consistency, accuracy, and also just generally improving the patient-clinician interaction as the patient and both the clinician can focus on the interaction rather than trying to memorize small minor details about the situation. So here's our quick design overview. How are we going to be experimenting and how are we planning on creating the design? So our experimental group in this case will just be the notes written by the AI. Our control group will be the notes written by physician. So basically in the clinician-patient interaction, the physician is still going to be writing down the note, but our AI will be used in this case to compare per each patient. So what are the key variables? Well, the independent variable, again, is the agent who's writing the notes, right? So in one case, it'll be the physician. In one case, it'll be the AI. The dependent variable, well, we're going to be measuring a couple different things. One would be the accuracy of the notes. So how does the note compare to the note written by the physician in terms of the accuracy of the content? So will the physician actually approve of the content the AI generates? The second thing is the time that's taken to actually produce the note. And the third would be the reliability of the note, the accuracy over a large scale and how reliable, precise the data is. Our control variables here, well, it's going to be the same setting. It's going to be the same clinic, and it'll be the same physician who's actually assessing the note. So when we compare the physician note to the AI note, it's the same physician who's actually going to be looking at both notes and saying, okay, one of these is actually more reliable than the other. And again, the experimental site will be the same. As well as the patient. So like I said, for each patient, one note's going to be actually created in real time with the AI, but the physician is still going to be creating their own human-based note. Like I just previously explained, again, the experimental group would be the patient's meeting with the physician. The AI creates a note based on the interaction in real time, while the physician is going to create a note afterwards, as they normally would. The control groups, again, it's the same patient's meeting with the physician, and it's the same physician who is going to be comparing the notes. In terms of, again, variables, the main important thing to notice here is that the independent variable would be the agent creating the notes. What we're really testing here is the difference between a physician human-based note and then an AI scribe-based note. So just to go over some control variables again, because it's important to see the comparisons to ensure that we can reduce for error and reduce for bias here. We've isolated 4 different variables to keep controlled. One would be who is actually assessing the note, who is using their subjective interpretation of the note to determine if a note is comparatively better. Then the second would be who is actually writing the note. So that way, when the comparer or the observer is looking at the 2 different notes, how can they see if maybe there's an error used, if there's error produced in the person writing the notes? And so we're actually keeping the same. It's going to be the same physician writing the notes. It'll be the same physician also assessing the notes. The experimental site will be the Gastroenterology Institute of Orlando. Will be the same. And again, the patient. Each patient will have 1 AI note and 1 human-based note generated. So the materials we're going to be using is our HSI Lab Scribe, AI Scribe, which will be the AI tool used for generating the SOAP note, a laptop to be able to actually input and run the AI model, the clinic at the Gastroenterology Institute of Orlando, patients, and then also the physician. And this is a human participants research, so we will be getting age range from adult patients who require GI and cardiology consultations. In terms of identity, gender, racial, ethnic, etc., we're inclusive. In terms of vulnerable populations, we are having no minors, pregnant women, prisoners, those with mental disabilities, etc., will be included. In terms of recruitment and methods, again, the participants will be those recruited at the Gastroenterology Institute of Orlando who are informed about the procedures about the study and will be consenting if they choose to do so. And there's no questionnaires or surveys post the study. And patients will just be, again, acting as if though they were having a normal consultation with their caregiver or with their provider, and there's only going to be 1 interaction per patient and physician. Generally, there's no risks or psychological issues involved. Again, the benefits could include healthcare efficiency in the long term, improves physician productivity, and benefiting patient services. And again, the data is going to be collected. Patient names will be redacted for anonymity. Audio recordings are going to be temporarily stored, and then data will be, again, deleted 3 years after the research is complete. Again, patients will be informed about the study and their rights before participation. They will be required to give written consent, and they can always opt out if they choose to do so. Well, thank you all for listening. It's been great to be able to work with everyone on this project, and I really hope that we can produce some great results.
One last presentation from one last student that I will ask you guys to entertain. What do you all think overall? This was the 3rd time we've done this next year. I might as well tell you. Let me thank Juan. Yeah, let me just thank everybody before everybody runs out of here. So Juan Santos, he has a laryngitis. Not possible without him. Advent Health, they sponsor this on the Sabbath, which says a lot. I guess this is not considered work. I'm a Seventh-day Adventist, and I hope it's okay. Um, Amoy, Dr. Frazier, everybody has left, but I really would like to thank them. Ashley, everybody who presented, all of the teams, Dr. Ramesh, his lovely wife, Chait, David Metcalf. I mean, there's no end in sight. The Dean, Dr. Chang, and all of you for sticking with us. I mean, it says a lot that you're here after 6 on a Saturday night, so I appreciate it. Thank you very much. And we have one more, and that's it.
Hi everyone. I'll not take much of your time. I am a second year master's student studying computer science at UCF. So it's kind of weird that I'm presenting a blockchain solution at AI hackathon, but bear with me. So imagine you are a billionaire. You want to donate some money for the needy, like a patient who is in a critical health condition. So, what do you think? You always want to give the money who is in real need, right? There is this trust issue over here. So, with the traditional system, there is a lot of lag in the process, and there are like privacy issues, and also there are a lot of other issues. So, we are like leveraging blockchain technology and the technique of zero knowledge proofs. What we do is the patient will be able to prove that he is having a diagnosis, and then we will be verifying it, and then the on-chain contract will be able to send the cryptocurrency to the patient in need. So the process goes like this. So a patient who is suffering from, say, stage 2 cancer, what he has to do is to generate a cryptographic proof using the ZK circuit, and then this circuit will be like verified off-chain, which increases the speed of the process. And once this is done, the smart contract, like the program that is written on the blockchain, will be like releasing the cryptocurrency to the patient. Here, we are not only like reducing the time like from days to minutes, but also we are building the trust between the donor as well as the patient. So this is the solution that I'm presenting. Thank you. Any questions you have? I know it's almost done. You can email me at my UCF mail ID. I'll present it to Dexter Hadley. Yeah, thank you.
All right, I am closing the party. I swear I'm only going to use 2 slides of my entire presentation, if you can find it. Right, is it coming up? I'm going to let my tech guy. First and last slide, or first slide. So for this project, I did a quick analysis of the trial, cancer trial data set, right? Because that's a big problem where only 3% of cancer patients are actually, no, so my slide with my name, Dr. Yuana Thiessen, LinkedIn. So only 3% of cancer patients actually sign up for the clinical trials, right? So that's 97% of all cancer patients who do not get to participate for some reason or another. And so partly is because of the data set, the data or the information is not available, it's not accessible, it's stored on .gov somewhere.
Are you ready to build the next generation of AI-powered chatbots and conversational agents?
President. Where's the first slide with my name? Dr. Yuana Thiessen. Yeah, so it is a problem because of the interoperability of the data, right? Data is in silos, they can't connect, they don't talk to each other, and so when patients want to find out where clinical trials are, it's extremely difficult because they're named differently, they're labeled differently, everybody talks about it differently. So what we're trying to do is to use AI and as well as RAG to help to organize the data, to make it easier to access, to build some kind of a standardization to it. And so I used 4 approaches, and then I compared those 4 approaches. I used a basic rule-based approach to build a matching. Then I used LLMs as another approach. I also used RAG additionally to the LLMs, and then I used the knowledge graph. So I used the 4 approaches, and then I used various metrics to compare the performance of those various approaches. And what the research showed, if my husband could ever find the presentation, honey, it's this. So that's not it. That's the video. That's not the presentation. So there, what you will see is that models, different approaches perform better for different types of data set. So sometimes the LLMs were more accurate, and other times the RAG was more accurate. Sometimes the not. Yes, right there. Before, after the video. Isn't that? The presentation I was working on all day today. But anyways, the point is that all of these different approaches are very effective for different types of situation, and they all work really well depending. So some were better with different phases of the cancer treatment, and others were better for different patient, different client, different features. So yes, we need to have these different approaches to help us better access the data, build better systems, better tools, but we need to also be aware that it's not a one-size-fits-all, basically. And so at the end of the day, as someone was talking about the hallucination and all of these other issues, we need to understand at a fundamental level, and that, I mean by us, the experts, how these models work, what they're doing, and making sure that we are using them to better, to get the best results out of them, right? Because as they were designed, they're only at 70% capacity. We need to now take it to the next level and make sure that we get the most out of it. And I will find the slide at some point, but thank you all very much.
Awesome. So we will talk about clinical trials. Let me thank all of our presenters. Here you go. For you. Thank you. Everybody wins a bag. We have one actual winner of the poster competition besides our high school student. And that is Michael. You got 30. Michael got 46 votes. I suspect most of them are from yourself, but that's okay. And Michael, I'm going to give you a bag. Here you go. You win the Hurricane Milton umbrella.
Thank
Because we rescheduled it. So thank you. Michael's a third-year medical student. The runner-up was Ebony. She's not here, but for the video, she would be the runner-up. And if you haven't received one of these gift bags and you're not from UCF, please come get one. Thank you all. This was awesome. We are 20 minutes over. I'm amazed people are still here, but I do need to go. So thank you, and see you next year.